So, Amy, what about your trip to Russia? You got all the bags packed?
I think she's still not sure.
Oh.
Well, at least I did my best to persuade her to reconsider, but yes, the bags are packed.
Amanda, I just don't get it. We've got all these wonderful doctors. You get all the medication you need. What's the point of going that far from home?
Mum, you see, the thing is...
Yeah, we do receive therapy here, but you know your daughter, Melinda. She says the new method they use in Russia can stop the disease for a long time.
I have made the decision. I am not going to change my mind.
You know your daughter. If she sets her mind on something...
Let's
talk to our reporter down there. Hello, can you hear us in Newcastle?
I got it.
It all started when my flight landed in Moscow. No, not really. It might have begun when I first saw my hands tremble, or when I bought my first wheelchair, when I first felt my husband getting colder to me.
Dear passengers, this is your captain speaking. Welcome to Moscow. On behalf of the crew, I thank you for choosing our airline and wish you a pleasant stay in Russia.
They say multiple sclerosis is not a death sentence. Of course it's not. We keep living every day, getting worse, losing our loved ones who are normal. We smile. We have to pretend to be happy and smile at everyone in order for people to be pleased enough to help us. MS is not a death sentence, no, not at all. It's a lifelong torture that has no end. Or does it?
This is Jones. Welcome to Moscow. I'm Alex. I emailed you a couple of days ago.
Oh, hi Alex. Yeah, I remember. It's so nice to meet you. You may call me Amy.
How was your flight, Amy?
Oh, quite alright. Just feeling a bit tired, you know?
Okay, don't worry. I'll be in charge of all of your arrangements here.
Sounds good. Thank you. Hello, how are you? Okay, thank you. Hey fellas, I'm here in Moscow and this is the airport. Just arrived and passed the passport control. It's actually way better than I expected. The guy from the clinic met me right in front of the plane. Oh, here he is. Alex, say hi.
Hiya. Amy, your luggage is here, so shall we go now?
Oh, yeah, sure.
Excellent.
This is the progression. Doctors know how to slow it down. You will get medication, treatments and stuff, but anyway, for many of us, a wheelchair and total dependency on loved ones is the only future we can expect. Dependency. This is what scares me the most.
Now we'll head straight to the hospital. We still have time to beat the traffic, so we'll go through the city centre so that you can see the nice views of Moscow in summer.
Okay.
I'm sure you'll love it.
Yeah, sure. Multiple sclerosis does not only affect your physical condition. It affects all aspects of your life, in fact. Over just a year since I was diagnosed, I've gone from a cheerful, independent, and attractive woman into an object of compassion, a daily burden for the people I love. I've come to Moscow to get a radical treatment for my MS and hopefully get my life back. There are very few clinics in the world that do this kind of treatment. A hematopoietic stem cell transplantation. Doctors will destroy my immune system that causes MS and make my body create a new, healthy one. It was a difficult decision, though. To go to a foreign country for several weeks, take chemotherapy, and face all the adverse effects. But if there is a chance, isn't it worth taking?
Welcome to the clinic. This will be your home for the next couple of weeks, and meet Anastasia. She will look after you now.
Hello, sweet. Nice to meet you.
Nice to meet you too, Anastasia.
How are you doing?
I'm good, thanks.
So we have a look. It's our hospital. We are home for a few weeks.
Ooh, yeah.
My dear, this is our floor. Hope you will remember.
I'll try.
And your room. Welcome, please.
Thank you.
So look, not so big, but I hope it will be fine for you for a few weeks. You will stay here. So maybe I introduce you a little bit. So tomorrow doctor will come. Now you have your dinner. Nurse will bring food to your room, and let's do it.
Yeah, let's.
Hello, Amy.
Hello.
Nice to meet you.
It's nice to meet you too.
How are you?
I'm fine, thank you.
Did you have a good trip?
Yeah, of course I did.
My name is Dr.Fedorenko. My
get it.
colleagues and I will get you through all the stages of HSCT treatment. I suppose you know how the treatment works, don't you?
Well, yes, I do, in general terms.
Our goal is to reboot your immune system. As you know, it doesn't work properly now and it attacks your own nerve cells.
Right.
Firstly, we will eliminate the cause of your disease, the aggressive immune system, using high-dose chemotherapy. And after it, we will transplant your own stem cells to reboot new, properly working immune system.
High-dose chemotherapy and stem cell transplantation sounds pretty terrifying, though.
Yes, Amy, I understand you. This treatment isn't a piece of cake. You should do some effort and you will have time to recover.
Will the treatment really get me back my normal life? I mean, will I walk out of your clinic as a healthy person?
At the same time, it depends on your own efforts, your support, your family's support, and treatment effectiveness. Amy, I understand your doubts. I know that you are worried. But look at the other side. This treatment has proven in cases much more difficult than yours. Everything will be okay. I think we will fight your disease.
Sounds cheering.
This is transplantation scheme. Firstly, we need to mobilize and to collect stem cells. We use special medication to stimulate stem cells, and then we use special collection machine like a harvesting machine or apheresis machine to collect stem cells and to provide deep freezing. After this stage, we provide high-dose chemotherapy. This is the most important stage because we can remove wrong immune system. It takes from 4 to 6 days. After this, we will give stem cells back and you will have 7 to 8 days time for recovery.
Okay. Let's do it.
Let's do it together.
Hey folks! It's been a while since I was last online. I'm nearly done here, and doctors say the treatment was a success. Pretty soon they're going to let me go home. Oh, Ginny, I have news for you too. Remember you had concerns about pregnancy? I met a young woman who works here in the clinic. She's pregnant, and it looks like she's about to give birth any day now. She told me she had MS just like you and me, and that she got the same AHSCT treatment here 10 years ago. So, here we go. And the doctor said the treatment method has actually become safer over the years, and it does not affect fertility in any way. Hope I've answered your question. Haven't I?
So, Hugh, are you going to watch the King's Address to the Parliament tonight?
Will it be at live? I guess I'll be at work. Not sure if I can watch TV in my office, you know.
It's all right. I'll let you know if it's worthy. By the way, where's Amy?
She'll be here in a minute. She was at the doctor's.
Doctors?
Yeah, she has an ingrown toenail.
Oh.
I'm home!
There she is.
Let me help you, honey. You mind here?
No. I'll do it.
I'll take it, darling.
I hope you won't take some songs. I got to buy.
Hello dear friends, and welcome to our new webinar today. And today we are going to discuss our recent result presented in European Bone Marrow Transplantation Conference 1 month ago. Also, I would like to share our plans and our new experience, and of course to answer all your questions. So I am really happy to meet all of you, and today with me also Anastasia. Anastasia, welcome to us.
Hi, dear friends. Welcome to Moscow. Right now, we all are here together.
So beautiful, Anastasia is here. She will help in our discussion and our webinar. So, and I think our first part of this webinar is my report and the key data I presented in European Bone Marrow Transplantation Group Conference in Florence 1 month ago. So I would like to share our experience, and the topic of my report was effectiveness of non-myeloablative HSCT, our Russian updated experience and factors associated with better outcomes. As everybody knows, transplantation is still highly effective and still promising treatment option for multiple sclerosis, and we have performed more than 2,000 transplantations since 2005. And the idea, the main philosophy of transplantation is to find the best balance between effectiveness and toxicity, to find the best time when we should do this treatment, to find the best protocol we should use to improve our early and long-term outcomes. So we analyzed almost 900 patients with different types of MS, 898 patients with a long-term period of follow-up, period of observation. So all these patients had different conditioning regimens. We started with our first one, beam-based protocol, then cyclophosphamide-based protocol, and our recent fludarabine-based protocol we started to use in 2022. So, and on this picture you can see, I think many people knows this picture, the evolution of our program to reach the best outcomes, the best effectiveness, and to reduce toxicity. And we can see key points of our program optimization. And these key points are stem cell mobilization. We stopped to use chemotherapy, and now we use only stimulating factors with steroids. Second key point is high-dose immunosuppressive therapy. We stopped to use beam-based conditioning as very toxic, switched to cyclophosphamide, and now we use cyclophosphamide and fludarabine-based protocol. The third important thing, we change ATG to rituximab. It's very important. We don't have virus complication. We don't have Epstein-Barr virus reactivation. And of course, it's very important to recommend people to try to organize early and late post-transplant care. If we compare toxicity of our protocol, we can see that toxicity of beam-based and cyclophosphamide-based was the same. Fludarabine-based protocol was much less toxic, with less rate of infection, less rate of cytopenia, and less rate of organ toxicity. Tragically, we had 6 patients who died, and the main reason was sepsis. And all these patients had cyclophosphamide-based protocol we stopped to use for multiple sclerosis now. And we can see our 5-year event-free survival in different group of patients. This is our updated results. We can see that 5-year event-free survival is significantly better in relapsing remitting multiple sclerosis. This is 87% to compare with secondary and primary progressive MS, but for secondary primary progressive MS, event-free survival is also high, around 80%. So it confirms that transplantation is effective for progressive variants of multiple sclerosis. I had this question in Neurological Society in St. Petersburg conference 1 week ago, also in Florence. Do we provide transplantation for progressive variants of multiple sclerosis? Yes, we do. Transplantation is effective as the same for primary and for secondary progressive multiple sclerosis. And we can see our risk stratification later. So also, as you know, we compared effectiveness of all 3 protocols. Actually, we didn't find any differences between beam-based, high-dose cyclophosphamide, and fludarabine-based conditioning. So effectiveness of 3 protocols is the same, but fludarabine-based protocol is much less toxic. And the next step, we try to analyze what factors are associated with effectiveness transplantation. We started to analyze such factors as age, gender, disability before transplantation, disease cause, disease duration, strategy of HSCT early when we do it as soon as possible, conventional when we do it in mid-stage of MS, when patient failed traditional treatment, and salvage transplantation when we provide transplantation in quite advanced stage of multiple sclerosis for patients with high disability level. Also, we analyzed presence of active lesions before transplantation isn't important or not, and quality of life, conditioning regimens, ATG use, and previous treatment. And what we found? We found that only such factors like older age, progressive multiple sclerosis, previous specific treatment, conventional and salvage transplantation, and bad physical health by quality of life assessment are really important. And these factors related to effectiveness of transplantation, but only in combination. So if we have 1 or 0 factors, we have low risk group. In our sample, this is 27% of patients. Intermediate risk group, 2, 3 factors, any of these factors. 2, 3 factors in combination, 40% of patients. And high risk group, 4, 5 factors, 33% of patients. So we stratified our 900 patients to 3 risk group based on our factors and what we have in our results. Interesting results. We can see that patients with low risk group have event-free survival 90%. The best result. Intermediate risk group. So we can see that also relapsing remitting multiple sclerosis can be in intermediate group if patient has other risk factors. So intermediate group 79% and high risk group 58%. Actually, if we think about the worst situation, very disabled person, progressive multiple sclerosis, heavily pretreated, high DSS score, so late transplantation, the worst result is almost 60%. This is not 90%, of course, but if we compare with traditional treatment, 58%, 60% is also good result. But this is the most difficult situation. And the next step, what we are going to do, we are going to improve these results. We are going to find something to do it better, especially for high risk group patients. We can see event-free survival curve. The best one is for low risk group, intermediate risk group, and high risk group. High risk group, if you analyze your personal situation, you shouldn't be upset. 60% is also good result, but now we can prognose our result, not to tell like 70, 50, 60, 90, we can do it analyzing personal risk factors. But another step, when we have this result, what should we do to deal with it? We need to work to improve it. So our results show that transplantation is still effective in all patients in different types of MS. And nowadays the safest protocol which should be used in multiple sclerosis is combination fludarabine with cyclophosphamide. It's important. The vast majority of patients have clinical and quality of life improvement during long-term period. So, and what is very important, the most important, 3 risk groups were identified: low, intermediate, and high. Actually, the best candidates for transplantation is young patient with relapsing MS, not patient who didn't have previous specific treatment, with a DSS score less than 4, and with good baseline quality of life. But I would like to tell you that this is combination. The best situation is 90% of success. The worst situation is 60% of success. but actually effectiveness is quite high, and now we go ahead to improve effectiveness, especially in high-risk group of patients. European Bone Marrow Transplantation Conference was a very big and great famous event in Transplantation Society in Florence. More than 6,000 participants took part, and I think 97 countries presented their results. More than 300 transplantation centers, and more than 2,000 scientific researches. Actually, it's great that our approach, I would like to tell you that we are the first who performed this stratification for multiple sclerosis using transplantation. And actually, we received high assessment of International Society, and our research was nominated one of the 100 the best researchers in the world for this year. It's great, but this is only science. Now we should go in clinical practice, and the next steps is our perspectives. Firstly, new lymphoablative regimen. This is future. CAR-T therapy started in some countries like a first phase of treatment. Only 5-10 years should pass to confirm that this treatment is good, but this is quite perspective technology. Also other approaches, but what we should do now to optimize conditioning protocol, to develop new technologies for rehabilitation, to change lifestyle, to support patients psychologically and physically after transplantation, and what we are going to do next to improve results, especially in high-risk group of patients. I think from June we are going to improve our lymphoablative protocol based on fludarabine. We give one more rituximab infusion in fixed dose 1,000 milligrams with quite short 7 days interval between second infusion. So chemotherapy is the same, stem cell mobilization is the same, but we give one more rituximab right after stem cell reinfusion, and second high-dose rituximab after recovery from neutropenic phase. I think using this approach we can increase the effectiveness of this protocol to give maybe additional 5-10%, especially in high-risk group of patients. So future will show, but it can't make worse. It can make better. And so additional rituximab increases dose fixed to 1,000 milligram, possibly decrease risk of relapse, possibly improve immunological recovery, it decrease minimal risk of Epstein-Barr virus reactivation. It will help to optimize our treatment result, and also this is additional B-cell depletion. So I am finishing, and I like this phrase: success is the child of audacity. We need to be brave, we need to work hard. And success is 1% of aspiration and 99% of perspiration. It means we should go ahead all together. We should work hard. We should do something, not to stay on the one place. And I am very thankful all our patients who help me personally and our team a lot, giving feedback, optimizing communication, giving information what should we do better to improve our service. And thank you very much. I'm ready for our second part, for our live discussion. Anastasia is here. Hello, Anastasia.
Hi again, doctor, and thank you a lot for your, of course, nice speech, like always, your inspiration and your words of support. And of course, we have our friends who want to ask questions. We are ready. And Emmanuel will be the first lady who starts today with questions.
Welcome. Hello, Emmanuel.
Hello, doctor. Well, the first question I have is, well, I'm a 58, almost 58 years old woman. I think I had SPMS for 30 years, almost, probably, without a lot of lesions, but at least 2 lesions in the spinal cord, 2 big lesions in the spinal cord. And my question is, well, and I started Kesimpta last August because I had 1 new lesion last January, January 24. So basically, if I read correctly and if I understand properly what you said, I'm in the group of, quite an intermediary risk group, I think. That's what you said. I'm 58, 30 years of SPMS, 1 new lesion, one new lesion last January 24, and under Kesimpta that I just stopped because I'm really thinking about HSCT. But another thing, I wrote to Dr. Burt because I read his book and he said when it's a SPMS, it doesn't work. If you haven't got any new lesion, it doesn't work. So basically, I wrote him a mail and he answered me, it is not going to work. What do you think?
Okay, very good and very important questions. Okay, we are in contact with Dr. Burt and we are friends. We meet each other in Florence. So when Richard Burt published his book, we didn't have too much information about effectiveness of transplantation. In the next book, when Richard Burt, Dominique Fudge, John Snowden, this is textbook of transplantation for autoimmune disease. There is a special chapter, this is 2nd edition, transplantation for progressive multiple sclerosis. What can I tell you now? This prognostic group also statistic and combine many patients. For example, high risk group, this is 40% from 900, so this is 200 patients, but MS is a unique disease. Each patient with MS is different. Actually, there are no 2 similar patients. So it's true to say that there are almost 3 million variants of MS. And we should make decision personally. The most accurate decision is personal decision. This is science, this is statistic. We try to systemize our result, especially when we work with big data. But personal decision is the most important thing. What about your situation? If we look to high-risk group, 60% of success is much better than 10-15% of anti-B cell therapy like Kesimpta. Another thing, patient has to use Kesimpta all time, delaying the disease, slowing down. Transplantation can be done only once without any further treatment. What we recommend in situations like yours? If patient has stable disease, no ADSS worsening, no new lesions, and secondary progressive phase, you're absolutely right, and I agree with Dr. Burt, we can wait. But your situation, you have 1 lesion, new lesion in spine.
In January 24, sorry.
So you have new lesion in spine. 1 year ago, a little bit more than 1 year ago, it means that your MS is getting down. Our position about spinal lesions is very important because spinal lesions are related to quicker progression and to high disability level. So, other words, the more lesions in spine, the quicker progression of MS. In situation where ADSS is decreasing for 1 year, we recommend transplantation. Also, situation if patient starts to have new lesions in spine with or without ADSS was, we recommend transplantation. We don't recommend only if patient is stable 1 and more year in progressive variant. Also, if patient doesn't have new lesions in brain and spine, especially in spine.
It was in brain last January. It was a small one in brain. I just felt a weird sensation on my cheek.
Yes, so also spinal location is much more important. But if you have new lesion, you still have inflammation. Transplantation effects on inflammation. Also, it's very important to see, does patient have signs of brain and spine atrophy? If patient has brain and spine atrophy on MRI, we don't recommend transplantation. So if you make decision to go to transplantation, welcome. We repeat all tests and we make personal decision together with you. Actually, we discuss with Neurological Society anti-B cell therapy in progressive variant. Nobody knows how it works because MS is more T cell related disorder.
Yeah, that's what I understood.
Of course, B and T, but more T. Kesimpta affects B cells. Transplantation reduces T and B cells. So if patient has inflammation, it doesn't matter, relapsing, remitting, or primary or progressive variant, we better decrease inflammation, affecting all wrong immune system. Of course, Kesimpta helps, but not halting, but decreasing inflammation. Transplantation can halt it. So, of course, your decision isn't very easy and you are not ideal patient based on our prognostic group. But if we compare anti-B cell therapy with transplantation, we have results which are much, much more effective.
Yeah.
What's about age? You are young. The oldest, you are young. The oldest patient we transplanted successfully was lady from London. She celebrated 70-year-old 1 month before admission to our hospital. Also progressive MS and transplantation was successful.
Okay. What about Kesimpta? How long do I have to stop it for?
3 months before is enough.
That's enough. Okay, because
3 months.
I just stopped it.
Yeah, 3 months is enough.
Okay, but it's still very scary. How do we manage it? I mean, do I have to sign for a transplantation without being sure that it's going to be done?
But transplantation can be done only once, not as a treatment after. And of course, every patient with MS has autoaggressive T and B cells. Of course, Kesimpta decrease MS progression. And unfortunately, we have many patients anti-B cell therapy who failed it after 1, 2, maximum 3 years. Of course, in your situation, there are 2 options: to do it now or to wait 1 or 2 years to see. But 90% that Kesimpta only delay MS progression but won't stop it. So of course this is your decision, but my position is to help make your decision. To make a decision, I am on your side. Of course, I am not going to push you to make this decision. We can analyze risk and benefits, mainly in our hospital. Of course, if your last MRI you had January 24, you can repeat. We recommend to have MRI once a year. Maybe now the time for new MRI.
But I had once, I think last October, yes, and there was no change after January 24th. So I don't know what to think about it. Is the answer in the progression between the first MRI and the last MRI? Like, for example, if I have in 4 years, would you be able to see if there is a progression in the lesions that were present like 4 years ago, and now can they change a little bit?
Sometimes it's complicated to compare, especially different machines, but the most important is your symptoms and your disability level.
It's getting worse. The disability is getting worse.
If it's getting worse, put on the first place your condition. MRI is the second place because sometimes patients from running to wheelchair never have new lesions. They down, 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 down with stable MRI from running to wheelchair. Because MRI is limited to detect damage on cellular on very low, on very small level. So some patients, especially with primary MS, have stable MRI all MS cause.
Okay, I understand.
So
another question, see if I have time, just what happened for the 30% for whom it doesn't work? Can they get worse?
No, only the same cause. Only the same cause. Transplantation can't make worse. Also, 100% it will stop it. But this is 30-40%. MS will start to progress with the same rate, usually in 2-3 years after. It will be temporary effect. But we hope it will be very long effect, maybe for whole your life. But transplantation can't make worse for progressive MS because modern protocol is very safe, almost zero toxicity.
Okay, and just another thing, why using rituximab if it just kills B cells and not T?
The main effect is based on chemotherapy because combination fludarabine with cyclophosphamide remove all T and B cells. We use rituximab because B cells recover quicker and can cause Epstein-Barr virus reactivation. Using rituximab, we additionally deplete B cells. Also, we prevent Epstein-Barr virus reactivation. Actually, the main idea of rituximab to save patients from Epstein-Barr virus reactivation, because the next step after reactivation is MS relapse. Epstein-Barr virus can be a trigger of MS. So this is additional protection and maybe additional minimal immunosuppression. But of course, the main treatment effect is a result of combination of chemotherapy. Without chemotherapy, rituximab can't work at all.
Yeah. Okay, so rituximab could kill the virus.
Could kill, could decrease amount of healthy B cells which repair very quickly, and all we have Epstein-Barr virus in our body. And after very strong decreasing of immune system, Epstein-Barr virus can reactivate and attack new healthy B cells. This is like a target, like food for Epstein-Barr virus, home for Epstein-Barr virus. So, and can be reactivated. So if we delay B cell recovery, we protect body from Epstein-Barr virus reactivation, and it's not a kind of MS treatment. This is a kind of better immunological recovery after chemotherapy. More optimal recovery after chemotherapy.
Okay, and do you have patients that go home without having the transplantation because you decided not to do it? Does it happen?
It happens sometimes, but more often it was two disabled persons with stable long MS, with high disability level, and with lots of brain and spine atrophy on MRI. Sometimes we receive documents which is quite old when it is 6.5, and then we have patients who can't move, eat, completely disabled, and this situation is quite long. Very rare we had situation that we find some other problem, healthy problem, which can, like more serious disease than MS. This is cancer, for example. But firstly, we need to treat cancer, then MS. But it's quite rare. Also, if patient tell us, doctor, this is your opinion, this is my opinion, let's discuss, I want to watch and wait, let's make second test and second reassessment in 1 year. It's also possible.
Okay. My other question was just, is it possible right now to repair lesions with mesenchymatome? Alors, I don't know how you
mesenchymal stem cells can't repair lesions. It can. Mesenchymal stem cells are not proof in many countries, including in Russia. Mesenchymal stem cells can, like immunomodulators. Mesenchymal stem cells do nothing for MS at all. What is the future? This is recent Japanese research of modified multipotent stem cells.
Yes.
Yes, this is Nobel Prize, I think 2012. This is future because this is stem cells which can repair nerves, but not mesenchymal.
Not neuronal stem cells.
Yes. But this is only clinical trial, only adult research. Maybe it's future. But to reach this future, we need to stop autoimmune process. And the place of transplantation is here. Also, if you want to repair nerve system, we need to stop destroying process. This is like a fire. The earlier we stop fire, the less we need to repair.
Okay, thank you very much. Thank you very much.
You're welcome. Good questions. Thank you. Have a nice day.
Thank you very much. You too.
Thank you.
Thank you, doctor. Really very good questions, very serious questions. And it's again a question about how it's difficult to make a decision even to do transplantation, about future maybe life. So
I think we answered questions of many patients because it was very important questions and covered many topics.
That's true, even for me, some new information. So anyway, doctor, let's continue. We have another nice lady, Ines. She also has some questions. Let's start.
Hello from Croatia. I have questions. I have RRMS. I have Epstein virus, and for 3 years I don't have new lesions, but clinically I'm not very well. I can walk only 100 meters without stopping, and it's only for a 5 minutes stop, and I can walk again 100 meters, and I need to stop again. I don't have new lesions for 3 years. Is that normal?
Okay. May I ask you two important questions for me to answer your question? Firstly, if you compare your condition now and 1 and 2 years ago, are you better, worse, or the same? If your 3-year dynamic of condition
diagnosed 4 years ago, and I had Ocrevus. And when I start to drink Ocrevus, I was I have symptoms like my legs don't work anymore like they used to do. I had ritmička sportska gimnastika and training in young years, and I'm sport deep, but I can't do the sport anymore. It's
look, my question is, if we analyze your 3-year dynamic, your MS is getting down?
Yes.
Your MS is getting down?
I'm worse.
Clinically, you're getting worse without new lesions?
Yes. Clinically, I get worse, but no lesions, no new lesions.
When you had MRI, did you check your spine, neck and thorax?
Yes.
All spine?
Yes.
So, did you have lesions in spine?
1 year, I don't drink any pills, any. I just don't eat sugar, red meat, milk, and milk products, and I feel little better, but not very well.
Okay. When we analyze clinical situation, we have two big important things. Medical assessment, this is neurological status, and MRI test. And patient-reported outcome, this is your personal condition, your symptoms, your quality of life, how you feel. And we need to combine both. If you are getting worse without signs of MRI, new MRI lesions, your MS is progressing. Because as I told answering previous patient, some patients with MS never have new lesions. From running to wheelchair. From year to year they are getting worse. And the reason is
that's me.
MRI is limited to detect inflammation on very small cellular level. So this is why our position to provide transplantation based on clinical picture. So in your situation, we recommend transplantation because your MS cause is quite typical, is going to change course from IMS to SPMS.
Okay.
There is a high risk to have secondary progressive MS in closest years.
If I decide to come to the therapy, how long therapy is? How long I need to be in Moscow?
1 month.
1 month. And how much it costs? Therapy.
I think it's better to discuss with our administrations because I'm responsible for medical part. So all organized questions about visa invitations, tickets, and other. We have special departments. Anastasia is also responsible for organization. They will answer. Today our topic is medical issues. So, but
do you think I'm a good patient for that therapy?
Yes, because you still have RRMS, relapsing remitting MS.
I still don't walk with a stick.
This is very important thing. We need to do it now to protect you from stick and further disability. You are still
after
in low
the therapy. After the therapy, do I need drink some medication?
No disease-modified drug, only vitamin supplements if you want, like vitamin D, but no special MS treatment.
Okay, so after the treatment...
No Crevus, nothing.
Thank you very much.
You're welcome.
You answer all my questions.
You're welcome. Thank you for good questions.
Nice, doctor. Again, more information for others as well. So, anyway, let's continue. We have another nice guy who also wants to ask you some questions. Laurent, welcome.
Hello.
Yes. Hello, nice to meet you from France.
Nice to meet you.
Well, I just give you a little bit the picture of my case. I'm 40 years old. I have been diagnosed for MS RR 2 months ago. And I have 2 spinal lesions and 30 lesions in the brain. Until now, I had only 1 relapse because it's 2 months only. And I did not start any treatment such as Kesimpta or Ocrevus. They proposed me at the hospital, but I was thinking about it. But some friend who did the treatment in your hospital told me about you. So I am still thinking about what to do because it's quite new. And to be honest, I feel not sick. I feel normal. I do sport. I do exercise. So I feel quite normal. So my 2 questions are the following. Would you suggest in my case to do transplantation or not? And if I do transplantation, would you suggest to start any treatment before coming to do the transplantation? Because for now, I don't have any treatment ongoing in my body.
Okay, good questions. If you saw my presentation and our result we presented in Florence 1 month ago, treatment-naive situation where patient didn't have a specific treatment before is one of the most positive factors associated with better result. If you analyze your personal case, you are the best candidate for transplantation. 40 years old and younger, relapsing remitting multiple sclerosis, low ADSS, no disability at all, no previous treatment, and good quality of life. 4 factors. So for transplantation, it's good. You have 2 choices: to start anti-B cell therapy, which is less effective, and to do transplantation. And of course, after transplantation, you won't need to have any specific treatment. This is good, but what is the most important thing I want to tell you based on your history? And we have the biggest single center experience of transplantation for MS. And this is also not from me and our experience, this is also a kind of neurological rules. If patient has spinal lesions in the beginning, risk to go to secondary progressive stage is higher than only brain damage. So spinal lesions in the beginning, when MS only started, is an favorable factors, because MS is quite unpredictable. Some people live 30-40 years without any problems. Sometimes MS is very aggressive, sometimes slow and then aggressive. The main cause of relapsing remitting MS, traditional, not slow, not aggressive, from good condition to bad condition, 10-15 years. Quicker with patients who have spinal lesions in the beginning, and slower for patients without spinal lesions. This is addition. This is not bad and not good. This is only fact and give us information that you need to start with effective treatment. Anti-B cell therapy is effective. Transplantation on the top. So our position, my position like hematologist, to give this treatment as soon as possible, especially for people with spinal lesions in the beginning. So I recommend transplantation. But this is your choice. Another option, to start anti-B cell therapy 1-2 years, to have good MRI control, and to switch to transplantation in case of low effect of anti-B cell therapy. So, but you should start any treatment. In neurology, the most effective treatment is anti-B cell therapy like Ocrevus, Kesimpta. So this is why they recommend to start it, because of, I think they also know about risk of spinal lesions. Because anti-B cell therapy in neurology, this is the most effective treatment, one of the most effective treatment. Transplantation, only transplantation more effective than anti-B cell therapy. So 2 options. We recommend transplantation. Of course, if not, start anti-B cell therapy, and then if effectiveness isn't enough, go to any hospital, to Moscow, to another transplantation center, but please don't change one anti-B cell therapy to another. In your situation, you should intensify your treatment. If you start with like Ocrevus, Kesimpta, and effectiveness is low, your patient failed this treatment, go right to transplantation. Or another option, start transplantation, 1 month treatment, and then only observation. Options.
But what is the difference in terms of risk to switch from RR MS to progressive MS if I do treatment or if I do transplantation?
Risk to have secondary progressive MS is quite high if you start with anti-B cell therapy, because MS is mainly T cell therapy disease. B and T, but mainly T. Every neurologist knows that MS is related more T cells and B cells. And if we reduce B cells, we only delay problem. High dose chemotherapy, when we use during transplantation, remove T and B cells. The differences between two approaches: anti-B cell therapy decrease amount of PAT, autoaggressive immune system. Transplantation destroy all wrong immune system and rebuild healthy one. This is why so different result.
Okay, and what is the risk to do the transplantation?
If we use modern protocol, 0. No secondary malignancies, no secondary autoimmune diseases. Risk was much higher for old myeloablative protocol. For new lymphoablative protocol, risk is quite low. But if you want to do some research, you can Google in the internet, because it was clinical trial. I think in 2012 or 11 published in JAMA Neurology, but you can make search, it's quite easy. It was a randomized trial. 55 patients with relapsing remitting MS received transplantation, and 55 patients received the best available treatment, mainly monoclonal antibodies like anti-B cell therapy. In 5 years, only 3 patients progressed in transplantation group, and more than 30 patients progressed in disease-modified group. It's published. It was not one country trial, it was international trial. You can find this article in the internet. If you can't find, be in contact with Anastasia, I have this article, we can send you.
Okay, thank you.
This is not our article, this is Europe together with the USA.
Okay.
Big clinical trial. So you can provide some research to make decision, or make your decision you feel by your heart. But my medical opinion, transplantation is the best for you.
Okay. Thank you for your time and your advice. Thank you.
You are welcome.
Thank you.
Thank you a lot again, doctor.
Yeah, well.
There's lots of information, very helpful for all of us and our friends at first, of course.
If you have requests from him, you know this article or not, I will send you. It's quite popular article which compared traditional treatment with transplantation for relapsing remitting early MS, and proved that transplantation is almost 10 times more effective. So also Richard Bird is one of co-author of this article. I have it on my computer.
No, super. We will share maybe again with for other patients as well.
Yes,
That's
yes,
nice,
yes.
doctor.
Because
We'll update. Anyway, we can continue. We have also friends who have questions, and I think are ready to do it.
Hello.
Yes. Hello, doctor. Good evening.
Hello, nice to see you. Good evening.
Yes, I am just a few words for me. I am 44 still. I was diagnosed in 2017, since 8 years, with rare MS. But the doctors now are doubting that it's going to secondary progressive. I have spinal lesions since the beginning, but with no change or increase in number since 2017. Okay, my EDSS is about 2.53, something like that, but I'm still active, physically active, walking and doing some sports. But yes, I feel a lot of fatigue and, of course, difficulty walking long distances, more than, for example, kilometer or something like that.
Okay, thank you for...
Yes, and I have never been on any DMT till now. Only twice I have corticosteroid therapy.
And did it help you? I mean, corticosteroids?
No, it doesn't help.
Okay,
Didn't.
so this is very important situation because spinal lesions and non-effectiveness of steroids is quite typical for progressive MS.
Yeah.
This is what I told before. Spinal lesions in the beginning usually cause to more aggressive MS course, quicker course to from relapsing remitting to secondary to switching course of MS from RR to SPMS. So this is why we recommend to do this treatment as soon as possible in situation with spinal lesions in the beginning. But your situation is very good. I think maybe you are not still really in secondary progressive course because changing course from relapsing remitting to secondary progressive sometimes takes time, not months but years. And for secondary progressive course is quite typical to have a DSS more than 5.
More than 5, yeah.
Important thing is if you compare your condition now and 1 year ago, are you getting worse or not?
Yes, I am. I feel.
If you are getting worse, you need active treatment and better transplantation because for progressive variant of MS, traditional treatment isn't effective at all.
Yeah.
Another thing, why MRI is very weak to detect dynamic in spine. Spinal dynamic can't be assessed by MRI carefully. This is why on the first position in situation like yours is clinical cause.
Yes.
Really,
Yes.
fatigue, to be honest, fatigue is the most troubling symptoms of MS. Many doctors don't know about it, but I think I am right. You wake up tired.
Yes, yes, exactly. Exactly. And doing some really light homework or house stuff, something like that is I need to lay down for a moment
tired,
just to relax.
Tired. But your fatigue can't be improved by rest, and this is very important because this symptom is related to autoimmune process, and this symptom can be better after transplantation. But of course, the most important idea to save you from high DSS score. If we stop it right now, and of course we can improve your quality of life, actually transplantation, why we recommend to do it as soon as possible in progressive variant? Because we can stop MS to prevent further disability, and we usually can improve condition to condition patient had 1 year ago. You can imagine your situation 1 year ago, and this is how we can improve. Sometimes we can do more, but common rules, if your DSS was 2, now 3, we can send you to 2 again.
Yeah.
If your DSS 6, 2 and 3 years, we can keep 6. This is common rules. So this is why you are a good candidate for transplantation.
And do you make some additional or recommended tests to be done here in our country to exclude other autoimmune diseases?
No, we can do it in hospital. We are not private. We are big university hospital. We provide complete body assessment, general health. Also, we provide brain and spine MRI with contrast using special MS program. And it will take 2-3 days for complete assessment. So not necessary to do it beforehand if you make decision to admit to hospital.
Okay, great. So everything could be done there. And
yes.
And anyway, if I decided to come, we could make another discussion for just to finalize the thing. Yeah.
Be in contact with Anastasia. She will help with organization. Also for medical question, I am open. You can schedule private talk with me using WhatsApp call, video call, no problems at all. If you have any additional question, we can discuss it privately.
Yes, thank you so much.
You're welcome.
For your
Lovely
expertise.
evening.
Thank you.
Thank you, doctor, again.
You're welcome.
But I have small surprise for you. We don't have any more patients who have questions. I think it's because patients are very highly educated and know maybe more than we know.
I think we answered. We had so important and so many and very wise questions. So we covered many questions from other patients. So and also after recording, and this webinar will be available for other patients. And I think my position, if we can help only one person to make right decision to stop MS, we can do 10 webinars.
That's true. That's true. But anyway, we are happy to share experience. It's the most important. People know about our work, and it's good and important for us.
Okay, thank you very much, Anastasia. And firstly, the main idea was to share our experience, presenting our result on the biggest conference in the world in Florence, receiving a high assessment of our activity, and finding lots of topics for cooperation with Europe and the USA in future. Also, the second, which I think may be more important, to ask some questions of our friends, patients who have ideas about transplantation, because sometimes to make decisions is very important and very difficult. We need to have lots of support in this time. So, and if Anastasia, if somebody has private questions, we can discuss time and do it privately, no problems. We are available all time for medical questions to me and for Anastasia for organization. So I think we can do it anytime. And thank you very much. I wish all our friends the best time.
And very nice holidays ahead.
And very nice holiday. Good. Thank you.
Bye-bye.
Bye-bye.